Rightly that we got the origin of SGLT2 inhibitors from the bark of the apple tree, and the aphorism that goes is an apple a day keeps doctor away. But we had to also look at the cost effectiveness of Apple. And today we are discussing about SGLT2 inhibitors that have proved useful and that have been very, and cost has always been an issue. So whether these SGLT2 inhibitors are also cost effective or not, and that's why we have the topic SGLT2 inhibitor revisited, economy versus benefits. So we know that diabetes mellitus is a highly prevalent chronic disorder, and this is an expensive disease. And this expense is of more relevance because in India, the cost of treatment of diabetes mellitus is mostly borne by individuals, and the cost has a large bearing, especially in low-income family, where up to 20 to 35% of their monthly income may be devoted for the management of diabetes mellitus. And where does the cost come from? The costs are direct or indirect. The direct cost may be the cost of consultation, anti-diabetic medication, laboratory test, cost of complications, cost of hospitalizations, and then there are indirect cost of transportation, absenteeism, then there are costs experienced by caregivers, and then there are cost of workplace discrimination and quality of life affection. And the journey of direct cost increases as the duration of diabetes mellitus increases, and as the complications increase, the direct cost involved in management of diabetes mellitus increase. So, and this is important in India because in India, as against the Western countries, we have to pay by our own pockets. So, on one hand, we have huge cost of management of diabetes mellitus, and on the other hand, we were disappointed regarding macrovascular complications of diabetes mellitus, especially when we talk about heart failure. And patients with type 2 diabetes and heart failure have a dismal prognosis. And from the landmark trials, we knew that only glycemic control does not go much in reducing the heart failure outcomes. So on one hand, we have huge cost, and on the other hand, we did have issues of not being able to reduce the complications of heart failure in type 2 diabetes mellitus patient. And what we knew about SGLT2 inhibitors before the arrival of results of CVOT trials were that they were good, that there were less chances of hypoglycemia, the action is insulin independent, there are reduction in weight, and improvement in renal parameters, and the rest involved were genital mycotic infection, UTI, DKA, polyuria. But by the arrival of results of these CVOT trials, which were originally done for testing non-inferiority but proved superior, and although these landmark trials have been different in terms of 3-point MACE, CV death, but what has been uniformly seen that there is consistent improvement in hospitalization for heart failure in all these trials, and also in CKD progression, as has been previously very well documented and explained by Dr. Sujeda. So we know that at least in hospitalization for heart failure and CKD progressions, these drugs have been consistent, and so we have huge benefit in terms of these parameters. And this has been uniform whether ASCVD is present or not. So when post hoc analysis of EMPA-REG was done, it was seen that EMPA prevented 793 events of hospitalization or mortality, and by treating 6 patients with type 2 diabetes mellitus and CVD, using empagliflozin, one additional event of hospitalization or mortality could be prevented. Number needed to treat was only 5.4 over 3 years. There was early and sustained reduction in risk of CV death, and this benefit, the time to CV death, got significance as early as day 59. From day 59, the benefit of time to CV death started to appear when the empagliflozin was used, and this prevailed over the whole of the treatment period. And also, from only on day 17, the time to first hospitalization for heart failure became significant, with those receiving empagliflozin gaining benefit. And similarly, improvement in sleep apnea. So on one hand, we know that cost of medical treatment is high. On the other hand, we have data that these drugs are useful in reducing hospitalization for heart failure. These drugs are useful in reducing DKD progression. But then comes the concept of pharmacoeconomics, whether they are really cost effective, and that is more significant in our country. So what is pharmacoeconomics? Innovative method that aims to decrease health expenditure while optimizing healthcare results. It covers economic cost versus benefit and humanistic aspect, quality of life, to assist in decision making of management choices. So there is cost minimization analysis. What is cost minimization analysis? This analysis assesses that at the same level of benefit, is it possible to reduce the cost as is possible when generic medicine is used in place of a patented medicine. Then there are cost effectiveness analysis. In this analysis, we study to gain 1 unit of benefit, what cost has to be incurred on. For example, to reduce fasting plasma glucose by one unit, what cost we have to pay for. And there are cost utility analysis, which combines cost effectiveness with quality of life. And then there are cost benefit analysis. So this study was done in US. Cost effectiveness of DPP-4 inhibitor and SGLT2 inhibitor combination therapy for type 2 diabetes mellitus. The objective of the study was to evaluate the long-term cost effectiveness of a strategy involving branded combination therapy with DPP-4 inhibitor and SGLT2 inhibitors. That was pathway 1, compared with generic alternative with sulfonylurea and insulin. The method was to extrapolate the findings of these landmark trials into the results. And it was seen that pathway 1 that were using SGLT2 inhibitors spent 15,000 more US dollars more than pathway 2 that were not using SGLT2 inhibitors, and with a reduction in complications rate and with a gain in life years of 0.133 and gain in QALY by 0.240. So the incremental ICER, incremental cost effectiveness ratio, that is derived from the change in cost by change in QALY. So to gain 1 QALY, the cost involved was 64,000 US dollars. And because this was less than 100,000 US dollars, it was considered cost effective. This value of 100,000 is derived from country's GDP. So as it was less than the said value of 100,000 US dollars, this was considered cost effective. And this cost effectiveness was seen when all these studies were applied, like Canvas, Empareg, CVD Real. Only in the cohort of old age, that is more than 65 years, to gain 1 QALY, more than the cost implied was 104 US dollars. So here it was not cost effective, but in all other parameters, the cost effectiveness increased, was more to, there was cost effectiveness, and especially when there is discount in prices for 25% or 50%, the cost involved to gain 1 QALY is less, and so the drug was considered cost effective. So the result conclusion was that it was cost effective. This is another cost effectiveness study done in Australia for use of combination dapagliflozin and metformin in patients with type 2 diabetes mellitus at the expenditure of 13,000 Australian dollars. The ICER, there was gain in one quality. So again, this was considered cost effective as the money expenditure to gain one quality was less than the was less than the threshold value. So this is the cost utility analysis of add-on dapagliflozin treatment in heart failure with reduced ejection fraction. As the willingness to pay increases, at low willingness to pay, the cost utility analysis of addition of dapagliflozin to standard treatment group is less. But as we increase the willingness to pay, as it crosses to more than 40,000 or 50,000, the cost it starts to become more cost effective. So the bottom line is the willingness to pay, and that's why if the willingness to pay increases, then the cost utility increases. This study done in France assessed that as dual therapy, as add-on to metformin versus sitagliptin, canagliflozin resulted in an incremental cost of 392 pounds, and the ICR was 30,000 pounds. And again, here canagliflozin was considered cost effective. Another study, a comparison of canagliflozin with dapagliflozin done in UK, showed canagliflozin to be more cost effective here in this study. So to summarize that, the treatment of diabetes mellitus is always expensive, and today we are discussing about huge benefit of SGLT2 inhibitors in terms of heart, in terms of kidney, in terms of even NAFLD, and apart from weight loss and other benefits. So of course, the economy will have to be taken into account. And actually, as we are hearing news about availability of a generic dapagliflozin, if that happens, then we would be able to do cost minimization. We would be, and these drugs would be able, would become more cost effective. But what is I found missing, that I could not find any data, Indian data, on cost effectiveness analysis of SGLT2 inhibitors. So Indian data on this cost effectiveness analysis would be of great help for us and for the government, to decide for use of these SGLT2 inhibitors, and so that we are able to translate these benefits to most of our population. With this, I come to end of this talk, and over to you,